Okay, so we are going to start the integumentary system, which consists of the skin and all the accessory structures associated with the skin. These accessory structures, as you can see up here, are the hair, nails, the various glands like sweat and sebaceous glands, and then there is this muscle as well called the erector pylorus muscle, which is a smooth muscle, which we'll see in the skin. So erector pylorus is a smooth muscle. So here, things like this, which are special, this is where you need to be paying attention and writing this down. Or if it's already there in your notes, just kind of highlight that. Erector pylorus is smooth muscle. It's supplied by a part of the nervous system called the sympathetic nervous system. So let's take a look at the integumentary system and all the structures that we are going to learn about.
The visible part of your skin, hair, and nails is mostly dead. The surface is the final resting place for cells that once grew below. The skin is the body's largest organ. It acts as a barrier against wetness, sun damage, and infection. The sweat and oil glands of the skin, exocrine glands, offer two types of protection. Perspiration cools the skin as it reaches the surface, and the oil glands prevent skin and hair from dryness and keep bacteria out. The hard surface of the nail protects the sensitive tips of the fingers and toes. Hair traps air next to the body, which reduces heat loss and helps keep us warm. The hair, skin, nails, and exocrine glands are all part of a protective network called the integumentary system.
So now we got the description of what the integumentary system is. So next we look at functions. As it said in that video, obviously the skin is the outermost covering of your body, so it is protective. Remember the kind of epithelium it had, stratified squamous keratinized epithelium. So this was a thick epithelium. It's protective. Plus the skin also has antibacterial properties, because sweat and the oil glands, which we'll see, they secrete substances which have antibacterial properties. So when you sweat, not only does it flush out any microorganisms which may be on the surface of your skin, so it prevents them from colonizing, but its antibacterial properties also kills some of these microorganisms. Skin also helps to maintain body temperature. So this is responsible for homeostasis. We did this when we were doing the introductory lecture, and as it said in that video. So think of this situation. If it's a very hot day, your body temperature starts to rise. So what happens is, where the skin is concerned, you begin to sweat a lot. When you sweat, that sweat on the surface of the skin evaporates and your body cools down. Also, you would notice that on a very hot day, you tend to look a little flushed because the blood vessels dilate. And when the blood vessels dilate and more heat is present under the skin, then that can be lost by radiation. So heat is lost at that time. Cold climate, when it's very, very cold, the opposite happens. Your blood vessels constrict. So less blood is flowing through the skin, so therefore less is lost through the skin. So heat is conserved. You don't sweat when you're when it's a cold day. Also look at the way you kind of on a really cold day, you kind of tend to sleep in a huddled fashion or even sit like that. So you kind of decrease the surface area from where heat could be lost, also, not so much in us, but in animals, when it's really cold, what happens is the hair stands up. And we don't have that much hair, but when the hair, that erector pylorus muscle stands up, heat is trapped between the hair, and that kind of helps to keep the animal warm. So you'll see the fur standing up. It's not that important for us, but you notice when it's very cold, you get kind of goosebumps. The oil glands in skin, and plus there in the epidermis too, we'll see that there is a certain amount of oil that's produced, and that forms a little coating over the surface of the skin, and that prevents water loss. So it conserves water in the body, and being oily, it prevents water loss. This also actually prevents a lot of water entering into the skin. So not everything really can be absorbed from the surface of the skin. Usually substances which are lipid soluble, or there are certain sort of enhancers in them which kind of help you to absorb substances pass through the skin. So not everything can be absorbed from the surface of the skin. Only usually oily substances. That's why your lotions and all tend to have a little glycerine in them, which kind of helps to absorb it. Excretion and absorption. Absorption I've already talked about. Excretion, so for example, when you sweat, certain waste products are liberated through that. So the skin is a very, very large, the largest organ, and so it helps to get rid of waste products. It also has metabolic functions. It's a huge place to store cholesterol and glycogen. And under the surface of skin, in the dermis, vitamin D is present in an inactive form. Under the influence of ultraviolet light, this vitamin D gets activated. When it gets activated, and then it goes further and gets further activated, and in the kidneys, it helps in the absorption of calcium. Vitamin D is important. It helps in the absorption of calcium. So it helps in the absorption of calcium. Calcium is required for bones. So then that calcium goes and gets deposited in bones. Initially, they used to think that the action of vitamin D had only to do with calcium and bone formation, and anybody who lacked or was not exposed to too much sunlight or did not have a calcium-rich diet, especially in children, they suffered from a disease called rickets. So, children who grow up in very closed, confined areas where the sun barely reaches them, so because of a lack of vitamin D, or it could also be that a child may be exposed to vitamin D, may get enough sunlight, but if they don't have enough calcium, they don't drink enough milk, or they don't get enough calcium from other sources, then calcium doesn't get deposited in the bones. So the bones get very soft, and that condition is known as rickets. So lack of calcium or lack of vitamin D can cause rickets. So initially they used to think that vitamin D was just important for bone formation. But now they know that vitamin D has a lot of other functions other than bone formation. It boosts your immune system. So that's why nowadays everybody is being told to make sure that your vitamin D levels are within normal limits. So it just doesn't act on bone or help with calcium absorption and then deposition in the bone, but has other immune properties. Then in the skin, we will see, in the epidermis of skin, we see these cells called melanocytes, and they produce this pigment called melanin. And the main function of melanin is to protect the nucleus of the cells from ultraviolet light. So the nucleus of the epidermal cells, it prevents it from the harmful effects of ultraviolet light. Another thing that melanin does is it gives skin its color. But that's not its primary function. Its primary function is, and we'll see it, actually, if there is a skin cell like this, and here's the nucleus, this melanin pigment sits on top of the nucleus like an umbrella, protecting it from the harmful effects of ultraviolet light. Because if ultraviolet light reaches the nucleus, it can cause mutations and can cause carcinogenic changes. So that's why you need to do that. And hence, you always asked to apply sunscreen and so on, so that you protect yourself from the harmful effects of ultraviolet light. Then apart from that, skin being the largest organ also helps with a lot of sensations that you feel. So we have special organelles in the skin which are known as receptors, which are able to help you feel pain, temperature, touch. So these are all cutaneous. Cutaneous means to do with skin. So you can feel these different kinds of sensations and differentiate between them. So these are some of the functions of skin. Next, let's look at the structure of skin. So skin basically consists of two layers. The epidermis, which is the top layer, and then the layer beneath it, which is called the dermis. But we also include another layer called hypodermis, hypo meaning below. So this hypodermis is this layer which you can see below the dermis. It's often whenever we talk of skin, we include hypodermis with it. But truly speaking, it does not belong to skin proper. But we always talk of hypodermis with whenever we are talking about skin. And this hypodermis is also known as the subcutaneous layer. Now here, look at this image carefully, and you can see these layers. Here's the epidermis, here's the dermis, here's the hypodermis. Notice this epidermis is very thick because this is where you have that stratified squamous keratinized kind of epithelium. Also, what I want you to notice here is that notice the epidermis. You can see this epidermis is kind of ridged like this. Notice how it's kind of has this wavy outline. And notice the dermis, which is below, which is the area where you find these sweat glands, you find this erector pylorus muscle, you find this hair follicle up here, you find the sebaceous glands, all of this, and you find blood vessels here in the dermis. All of this is present in the dermis, so here's something to look at. Also notice how the dermis now sends up little projections. Do you notice these? These are called dermal papillae. So what they do is when they send this projection up, the epidermis at that point is also raised up, and then the part next to it, it comes down. So they kind of form like pegs and they connect with each other. And this prevents the epidermis from being separated from the dermis. And we'll be talking about these dermal papillae, but I want you to kind of pay attention to these dermal papillae. Okay?
So what do they do?
We'll see. We'll talk about it. Yeah, I'll come to that. So let's look at the epidermis first, and we'll look at the layers. Remember, it's called stratified squamous keratinized epithelium. So stratified means it has many layers. Now in skin, in the epidermis, these layers are named, and we go from below upwards. Stratified squamous keratinized epithelium. And these layers are named. And we'll go from below upwards. The bottommost layer, which you see, it's the basal layer at the base. So this is known as stratum basale, or also known as stratum, you may see in some books it is given as stratum germinativum. Germinate. Germinate means to form something new, right? So this is the layer where cell division occurs. So you can see these mitotic figures. So look up here. Here's a mitotic figure which shows you that. So that's why if you pay attention to the pictures, you'll kind of get an idea of what happens there. So this is called stratum basale, stratum germinativum. This is the layer which is made up of cuboidal cells usually. And it is the area where mitosis occurs. So cells form from here and then they travel upwards and go right up to the top. It's a single-celled layer, so there's only one layer here, up here, the stratum basale. And in the stratum basale, you have these cells called melanocytes. So in the stratum basale, you have melanocytes, which you may see a few of them in the second layer that we'll talk of. And we also see a touch or pressure receptor called this Merkel cell. So see this cell, this is one which is responsible for you to feel touch or light pressure. So this is a receptor which is present in the epidermis. Most receptors are present in the dermis, but here is one receptor present in the epidermis, this Merkel cell. The second layer is called stratum spinosum. It's actually many layers thick. So notice this stratum spinosum, look at this, many layers thick. It's called stratum spinosum because if you can see these spiny little thing, can you see these little lines coming out? These are actually desmosomes. You remember when we did the cell, we talked of cell junctions, and desmosomes was something we talked about, right? Which attach cells together so that they act like a sheet. So these represent that desmosome. So usually you see this cell as looking very spiny, because when we process the tissue, because of dehydration, the cell shrinks, but those desmosomes still attach it to the neighboring cell. So it gives this prickly appearance. So often it's also known as the prickle cell layer. So it's many layered thick. And in this layer, you see cells which are phagocytic in nature. And these cells are called Langerhans cells. So you can see these Langerhans cells which are phagocytic in nature. So they help with the immune response. So that's the second layer. The third layer is called stratum granulosum, because it's got granules in them, and those granules are obvious. You can actually see those granules. Those granules are, there are two types of granules we see. Keratohyalin granules, which are responsible for final formation of keratin. So in this, we see keratohyalin granules, which are responsible for the final formation of keratin. That's why they are called keratohyalin. And then we also see another type of granule. You cannot differentiate in the light microscope between the two. Another type of granules, which are known as lamellar granules. And what lamellar granules do is they secrete a glycolipid, so like an oily substance, which goes out and it coats the cell on the outside. So imagine this is a cell with these lamellar granules. It goes and coats the cell on the outside with this oil, and also makes this cell very thick, so it kind of makes it protective. Because of this coating on the outside with oil, it prevents water loss. So keratin, actually, you have little keratin filaments present in the stratum spinosum, and as these cells kind of keep multiplying and growing up, and they come into the stratum granulosum, then you actually begin to see, you can't see the keratin filaments up here, but here in the stratum granulosum, you begin to see these keratohyalin granules. And then as we go further, these keratohyalin granules now get condensed as keratin filaments. The nucleus and other cell organelles die. So the cells in the next two layers are dead cells with keratin filaments very clearly defined. And the other organelles have died. So the nucleus disappears. You don't see any of the other organelles. So in the next two layers, the layer present here, which is kind of a gray-blue layer, which is called stratum lucidum. Lucid means clear. It kind of looks like a clear layer when you look at thick skin. This is only present in thick skin. That means it's only present in your palms and soles. It's not present in, for example, your skin over your forearm or your trunk or your face or anywhere else. Wherever there is hair, it's not present in that area. Only in the palms and soles. And again, it consists of dead skin cells which are going one on top of the other. And then the last layer, you see these cells. Again, they are very similar to the cells here. So this last layer is called stratum corneum. And here the cells actually can flake off. So they flake off. In fact, the dandruff that if you ever suffer from is really that. And every day we shed these dead cells. When you exfoliate, for example, you're kind of removing these layers. In thin skin, you remove this. In thick skin, you remove this other layer. So it takes a while for keratin to form. It takes a cell a really long time to go from the bottom to the top. And as it is traveling from stratum basal and going right up to the top, that's where keratinization starts. So, you have precursors of keratin up here in the stratum spinosum. Then it comes to the stratum granulosum where the keratohyalin granules are better defined. and then it goes up, and then the nuclei and everything gets lost, and only the keratin filaments remain. So this process is known as keratinization. People, you may have heard of this condition called psoriasis, which is an autoimmune condition. Here, this process of keratinization occurs really, really fast. So the cells kind of go up real fast. So what you'll see is on the surface of the person's body, you'll see these thickened areas. They are like plaques, which keep peeling off. And that's because the cells travel very fast from the bottom to the top. Okay, so that's what you see in psoriasis. So let's do a little review. What is the primary function of the melanocytes? Mm-hmm. Very good. The primary function of melanocytes is to protect the nucleus, not to give skin its color. The primary function is to protect the nucleus of the keratinocytes. Now, why do you think the superficial layers of cells are dead? Very good. They are far away from their source of nutrition. Remember, epithelium was avascular. So you can't forget, even though we don't have cumulative exams, you can't forget what you learned in the previous unit. Epidermis is nothing but epithelium. Epithelium was avascular. The blood supply comes from the dermis, which is below it. So the further you are away from the source of blood supply, which is the nutrition you're getting, the more likely you are to lose to die. So that's why they die. It's not because there are no melanocytes in those layers. Melanocytes don't have anything to do with nutrition. They only give skin its, they protect the nucleus from the ultraviolet light, and then another function was to give skin its color. Okay. Another question. What do you think is the function of the last layer, the stratum corneum? Think carefully on this question. Okay, the correct answer is B and C. The function is not to cause the skin to flake off. That's a side effect. I mean, do you really want your skin to be flaking off all the time? No, right? That just happens because the cells are dead and they're stacked one on top of the other. It is protective. It does waterproof the skin. So these two are functions. So you really have to, when you look at this thing, use common sense. So these are the two correct answers. So B and C was correct. So let's look at all the cell types that we saw in the epidermis. All the cells that you see in the stratum spinosum, in the granulosum, in the stratum basale, other than the ones others mentioned here, these cells are known as keratinocytes because they have those precursors of keratin, and then they give rise to finally to keratin. So they form about 75 to 90% of the cells. The second type of cells that you see are the melanocytes, whose primary function is to protect the nucleus, but they also give skin its color. The third is Langerhans cells, which we see in the stratum spinosum. These are also known as dendritic cells, and their function is phagocytic, so they help with the immune response. The last was the Merkel cells. These are also called Merkel's discs. These are responsible for touch and pressure, so they act as receptors. So they're receptors present in the epidermis. Now, all of us are born with a certain number of melanocytes, and we all actually have the same amount of melanocytes. The number in all of us is pretty much the same. It is only the amount of melanin that each melanocyte produces that gives us the various colors that we have. In someone whose melanocytes are producing more melanin, their skin color is a bit darker. In those whose melanocytes produce less melanin, their skin color is much lighter. Now, when you tan, when you go out in the sun and you get to be a darker color, what happens is under the influence of ultraviolet light, the melanocytes get stimulated and they begin to produce more melanin. When there is more melanin, obviously your skin color darkens. So while tanning, it is not that the number of melanocytes increases, but the amount of melanin that it's only the amount of melanin that each cell produces, each melanocyte produces, that increases. And so because the amount increases, the skin color darkens, okay? So remember this, that the melanocyte number is same in all of us. It's just the amount which is being produced which gives the skin its color. And under the influence of ultraviolet light, again, the number doesn't increase, but the amount increases and makes your skin get a little darker in the effort to protect the nucleus even more from the ultraviolet light.
So people who naturally just have darker skin, their cells just produce
More melanin, yes. Yes. Here are some conditions. Psoriasis. Here is psoriasis. You can see this is you can see this plaque formation because of this excessive keratinization seen here. And then we have another condition which is called vitiligo, which is again an autoimmune disease where the melanocytes are affected and they've ceased to produce melanin, so they are killed off. So those areas become patchy and have no color in them. So this is a case of vitiligo which you see. It's in autoimmune diseases, your immune system goes wrong. It's not able to recognize your body, and so it begins to attack its own cells. So everybody suffers, whoever suffers from autoimmune disease, the areas affected are very different. So in some cases it's here. In some people, you've heard of multiple sclerosis where it affects the myelin there. So it's one of those conditions. So let's look at the overview of epidermis, and this is a histological slide that you can see. So if you start from the bottom, so you can see the type of epithelium is stratified squamous and it is keratinized. It is avascular. There are 4 types of cells that we saw. There are 4 distinct layers, except in thick skin we have that stratum lucidum. The 5th layer is there only in thick skin. And up here on a histological slide under high power, you can see the lowest layer would be stratum basale. All of this is stratum spinosum. You can see the granulosum. You can actually see the granules even on a histological slide. Then here is lucidum, which is kind of a clear layer. And then here you can see the stratum corneum. You can see the cell outlines, but no nuclei present in them because all of those organelles disappear. The next layer in skin is the one which is below the epidermis, and that's called the dermis, made up of connective tissue, which is loose areolar connective tissue. So you can have loose areolar connective tissue, or you also have dense irregular connective tissue. In the dermis, you will find hair follicles, you will find glands. These glands are called exocrine glands because they secrete, and their secretions are carried to the outside by means of ducts. And we'll see nerves and blood vessels. We'll also see in the dermis, you also see receptors. Now, there are two major regions of the dermis. The one which is just below the epidermis, which throws those papillae. If you remember, we saw those projections which were called papillae like this, called dermal papillae. So that layer is known as the papillary layer or papillary region. It's made up of primarily of areolar tissue. And these dermal papillae, as we saw in the previous, so if we go back, we saw it in the first slide that we were looking at. Here. So here are those dermal papillae which are thrown by the papillary layer. So that's why it's called the papillary layer. What they do is they raise the epidermis above it. So they cause this epidermal area to be ridged. So they end up forming what are known as epidermal ridges, which are like whorls or circles. And these ridges are very, very prominent in your palms and soles, and that's what's responsible for your fingerprints. So the arrangement of the papilla in this papillary layer is unique to everybody. And that's what's responsible for the unique type of fingerprints that we have. The layer below it, which forms the majority of the dermis, here the connective tissue is dense and irregularly arranged. So it consists of dense, irregular connective tissue. And this is known as the reticular region. And if you remember connective tissue, what did it contain? Fibers, right? Collagen fibers. So in our body, in this reticular region, the connective tissue fibers, mainly collagen fibers, they are arranged in a specific pattern. The way they are arranged, that pattern is known as cleavage lines. So if you look up here, look at your trunk region up here. So notice they are arranged in a circular fashion, going around the trunk like this. In your limbs, if you see, they are kind of arranged a bit more vertically. So in your limbs, they are arranged a bit more vertically. Look at your face area up here on top, arranged vertically. Towards your cheeks, they are arranged in a horizontal fashion. By knowing the way these cleavage lines are kept, surgeons, especially plastic surgeons, make use of this knowledge. Because if you cut along the cleavage line, so let's say you have to make an incision, you made an incision along the cleavage line up here, so what will happen? The wound will not gape and healing will be much quicker and, with less scar tissue formation. On the other hand, imagine if you make an incision like this straight down, what happens? The collagen fibers will pull, the wound will tend to gape, and with the result, your scar tissue will take longer to form and it might be very thick. So now, not always can we go along the cleavage line. Sometimes you need to go against it. But most of the time, people, in order to have a cosmetic effect, we go along the cleavage line and it helps with healing. So we look at these individual layers, and here let's take a look at the region. So here you can see this papillary layer. So you can see these dermal papillae pushing the epidermis up. So here it's kind of forming a ridge. And so this is 20% of the dermis, loose areolar tissue primarily. The next layer, which is the majority of the dermis, is this reticular layer, dense, irregular connective tissue. And in this, you can see we find major blood vessels. So they're very large towards the hypodermis side. And as they come up, they get smaller because they give off branches. And you can see up here in the dermal papillae, you have a capillary plexus up here. And that's how the epidermis gets its nutrition. Here are sweat glands. So you can see this kind of sweat gland is known as an eccrine sweat gland. See, notice this up here. Then we have this muscle, this smooth muscle, which is called the erector pylorum or erector pili muscle. We also have these oil glands known as sebaceous glands. And notice, I want you to pay attention to the fact that these sebaceous glands are located next to a hair follicle. So this part here is called the shaft of the hair, the part that you see. The part that's buried inside the dermis and covered by connective tissue sheath and epithelial sheath. This area is known as the hair follicle. So notice in the angle between the erector pylorum and this hair is where this sebaceous gland is present. So don't write, just understand what I'm going to say. So what happens is when this erector pylorum muscle contracts, what it does is it kind of stands up straight. It kind of contracts like this. It makes this hair stand up straight and it squeezes this sebaceous gland, and that's the reason why it's present between the hair follicle and this erector pylorum muscle. When this gland is squeezed, it pours its secretions into the hair follicle because its primary function is lubrication of the hair follicle, and it provides oil and it lubricates the hair follicle, and then coming out through the pore of the hair follicle, that oil also coats the outside of your skin. So here pay attention to these sebaceous glands, and we'll see them in greater detail when we go along. Then here you can see some receptors present. So this one here is known as the lamellar corpuscle. We have some what are known as free nerve endings, not shown here. We have something called free nerve endings which are responsible for pain. So they are also present up here. This area here is like a free nerve ending. And you can see a lot of sensory nerve. Here are the free nerve endings. You can see up here and up here. So these are the free nerve endings, so richly supplied with nerves as well. Now in some areas of your body, especially along the joints, you will see some creases which are present. So, if you look at your elbow, your knee, in your neck, these are friction creases which are present. They're called friction ridges, which are produced by movement at that joint. So nothing really very special about them. Here is a histological section of the dermis. So here is the papillary layer. And here is the reticular layer where you can see this dense, irregular connective tissue. And because it's irregularly arranged, that helps the skin to withstand forces from different directions. So that's the function of dense, irregular connective tissue, to withstand forces from different directions. This is also showing you thin skin. This is the epidermis. So in thin skin, you will notice that the keratin or stratum corneum is much thinner than in thick skin. In thick skin, this area is very, very thick. And here you can see the stratum basale. You can see certain sort of brown spots inside, and that's because of the melanin present here in stratum basale. Now, skin is often subject to a lot of injury, and it tends to heal quite well. The difference is that if the wound is very large, it takes much longer to heal because that area has got to be filled. If the wound is close to a joint, again, that sort of makes healing take longer because, you constantly move that joint and then you can keep breaking the scab. If there is poor blood supply to that area, or there is infection, or a person suffers from diabetes where, there's too much sugar, which again makes that person prone to infection and less blood supply. Age, people who are much older take longer to heal. What else? Give me something else which kind of delays wound healing. Smokers. If you smoke, nicotine tends to cause vasoconstriction. So blood vessels are constricted and not dilated. So again, poor blood supply. So that again affects healing. That's why they always tell you if you're a smoker and you're going in for surgery, they'll always want you to stop smoking. Apart from all of the other effects that it may have, wound healing becomes very poor. So let's look at the phases under which wound healing occurs. So there are 3 phases. The first phase, which is about 2 to 5, so it's a short phase, it's known as the inflammatory phase. Because here cells kind of come in, whenever there's a wound, there's kind of a little inflammation going on over there, cell debris is there, so you've got to kind of remove all this. So first, what happens is that when you cut yourself immediately, or you have a wound anywhere, there is first a small degree of vasoconstriction. So the blood vessels constrict so that they don't cause excessive bleeding. So they want to provide homeostasis. After which the blood vessels dilate and blood fills that area. So it kind of forms a little clot, and you would have noticed that. And that attracts the platelets which help in the clotting of blood. Then macrophages and neutrophils are brought to that area, and they kind of eat up because these are phagocytic, they eat up all the cell debris and all the harmful products that are there. And a scab forms on the top because the clot dries. And you may have noticed, if you've ever kind of just scratched your skin on the surface, after some days a scab forms. After this, underneath actually the epidermis, a lot of work is going on, and this is known as the proliferative phase, or also called the organization phase, because a lot of proliferation is going on. Here, underneath, in the dermis, the fibroblasts, because remember that was connective tissue which has fibroblasts. So fibroblasts proliferate in this area, they lay down collagen and ground substance, and they try to bring the edges of the wound together. Capillary, because the blood vessels were also cut in that area, those blood vessels now begin to form tiny buds, and capillaries kind of try to join each other and bridge the gap. And then in the epidermis, the basal cells, they begin to divide, and they start kind of traveling towards the midline in order to approach each other and fill the gap. As the surface cells start to form this, the scab is lifted off. It's at this stage that vitamin C, you may have all heard that if you've ever gone for surgery or had a wound, they tell you that take a lot of vitamin C. Vitamin C helps in collagen formation. So it's in this stage that taking vitamin C kind of really helps. So as soon as you get a wound, you want healing to occur fast and well, vitamin C will help you. After this phase, from 3 weeks to years, this next phase or final phase is known as the remodeling phase, or used to be called the regeneration phase here. So new collagen forms, and that increases the strength of the scar tissue, though the strength is only about 80% of the original tissue. So you never get back to exactly normal, but close to. So here are the 3 phases. So here you can see first a clot will form, and then a scab will form. After this, in the second phase, then over here, the collagen begins to form, the blood vessels kind of start joining each other, and these cells in the epidermis will start to try and approach each other. Obviously, the wider the wound, the more difficult it is to do that. And then here's the final remodeling stage. So let's take a look at wound healing. Okay, looks like this account's been removed. So anyway, I have a video of wound healing in your notes, so be sure to take a look at that. Okay? So tell me, which of the following situations do you think will delay wound healing? all of the above. Yes, age, picking at a scab. When you keep picking at a scab, what happens is you pick at the scab, you cause bleeding to occur. So those blood vessels, those little buds, those capillary buds which are formed, they get torn again. So then again, they have to join. So they're picking at a scab. Location and blood supply. Remember I told you, location matters. Wounds which are over joints heal slowly. Blood supply to that area is poor. So for example, cartilage heals much slower than muscle tissue. Tendons heal slower than bone. So if you have a fracture, that will heal much faster than if you have, for example, a sprain where a tendon is stretched or torn. Infection. If the presence of infection will always delay wound healing. So all of this will affect wound healing. Okay. What is regeneration of the epidermis primarily brought about by? Which of these layers helps? Stratum basale. Stratum basale. Corneum is dead. It cannot help. It has no cells, so it cannot divide. It's stratum basale, which is called stratum germinativum. Remember I said the basal layer the cells try to get close to each other. So it's stratum basale. Stratum spinosum, also in the initial layers you can see mitotic figures, but stratum basale is the most important layer which kind of helps to bring about the edges of a wound together. Which of the following cells is important in the immune response? So this is a review. Langerhans cell, yes. Merkel cells are receptors, touch receptors. Langerhans cells are cells which aid in the immune response. Who has more melanocytes? Neither. They have the same relative number. Remember, the number is the same, it's just the amount of melanin produced which differs. So all this while we've been talking about melanin and saying that that's what gives color to the skin. But it's not only melanin which is responsible for skin color. There are two other pigments responsible for skin color. So those are carotene, which is a yellowish pigment seen in the stratum corneum and parts of the dermis, and the hemoglobin flowing through in the blood, which flows through the dermis of the skin, that also gives rise to the color. That gives rise to the pinkness that a person has. Melanin is responsible for the various hues that we see. We see somebody who's really pale skinned, and we might see someone who's extremely dark skinned, and then in between we see a variety of hues. That is because of the amount of melanin. Carotene, all of us have, and that gives a little yellowness to the skin. Not too much. Those people, carotene is seen in carrots and other vegetables which have a lot of reddish color in them. Pumpkins are another one. Eating too much of this might give a little bit more yellowness to the skin. And hemoglobin is because of the blood flowing through the skin, and that gives rise to that. So all these three are responsible for skin color. And in melanin too, there are different types of melanin, especially when we look at hair color. Melanin could be eumelanin and phaeomelanin. One of them is responsible for the brown color hair that people have. The other one's responsible for the red color. And lack of too much melanin gives rise to blonde color. Having too much melanin gives rise to the really dark colored hair. So the amount of melanin kind of varies, and the type in your hair also varies. Now here are some clinical observations that you may have seen. You've seen people with freckles. Freckles is just areas of concentrated melanin. So very, very fair-skinned people tend to have that. So these are just areas of very, very concentrated melanin. Albinos or albinism is a condition where there is no pigment at all, because in the production of melanin there is an amino acid called tyrosine, which is kind of broken down and undergoes metabolism. So there is a lack of this enzyme called tyrosinase, so it prevents melanin from being formed. So that's why these people are extremely fair-skinned. Their eyes, even the lashes kind of look blonde. So they have really no skin color at all because of lack of melanin. Vitiligo I already described. That was because the melanocytes were being killed due to the autoimmune disease. So this is patchy white areas that you see, which is slowly progressing. Tends to occur more in the begins in the extensor surfaces and then carries on. Then we might have conditions where the skin color changes, and we can actually diagnose conditions. Sometimes when there is lack of oxygenation, so when the hemoglobin is not carrying the normal amount of oxygenation, so there is lack of oxygenation of blood. So there's a lack of oxygenation of blood. That gives rise to a bluish discoloration of skin and mucous membrane. So the skin and by mucous membrane, I mean, the lining, for example, your oral cavity, your tongue, the epithelium over that, in your eyes, all these areas look bluish in color. That condition is known as cyanosis. This usually occurs if there is a cardiovascular or respiratory problem. So in cardiovascular and respiratory diseases, cyanosis is something that you see. Erythema is a condition where there is a reddish discoloration of skin. Usually due to increased blood supply to that area. So blushing is one example. Sunburn is another example of erythema, usually depending on the area where you see that reddish discoloration. Jaundice is a condition where there is yellowish discoloration of the skin and mucous membrane. So here you can see the skin, and here over here, look at this. Up this area, the scleral area, this is yellow in color. And that is because of bile pigments which are increased under the skin. And that gives rise to this yellowish discoloration. Jaundice is usually seen whenever there is anything to do with the liver or accessory structures. If there's a problem with the liver or accessory structures, like someone has hepatitis or something like that, then you'll see jaundice in those conditions. Yes?
So when babies are born that are jaundiced, like my son was jaundiced and particularly his son, why are they born that?
Yes, a good question. When children are born, it's not unusual. within the first few days to find that their skin has a yellowish discoloration. That's called physiological jaundice. The reason is that when a child is born, they have massive red blood cell destruction. And that the liver is not mature enough to handle all of that red cell and, remove all the bilirubin pigment that is there. So that collects under the skin. And what they do is they put them under this light, and that kind of helps with the removal of that pigment. So that is physiological. It goes away in a few days. So that's normal. That's nothing. But here when we see this kind of a jaundice in an adult is that there is some problem, definitely. Okay, so that's usually hepatitis or anything else that can happen. You can have an obstructed gallbladder, obstructed bile duct, and then this bile pigment can increase in blood, and you see it under the skin. Okay, let's review a little bit more. Which layer is responsible for the characteristic fingerprints unique to each individual? Papillary layers, yes. It's not the epidermis, it's the papillary layer of the dermis that's responsible. So let's stop here, and we'll continue with the accessory structures. Okay, all of these accessory structures, which are hair, oil glands, sebaceous glands, and nails, these are epidermal derivatives. So what happens is during development, cells from the epidermis sink into the dermis, and they begin to form glands, they begin to form the root of the hair follicle, they begin to form sweat glands, sebaceous glands, and of course the nail is again an epidermal derivative. Now let's see how they kind of sink in. So if you remember, the epidermis was multi-layered. So you had stratum basal, and then you had other layers on the top like this. So I'm not going to draw all of them. And then you had keratin. It would be thick if it was in thick skin, thin if it was thin skin. Let's say this has to go form a sweat gland. So if you look up here, so this area is the epidermis. This is the dermis in which you can see this hair follicle along with a sheath around it. Here you can see the sweat gland. You can see the sweat gland. This is a sebaceous gland. So let me say that a sweat gland has to be formed. So what happens is this epidermis goes down inside. And if you remember when we did tissues and we were talking about epithelium, we said epithelium was the one which forms glands. So here this goes in and then gets highly coiled. So it will kind of coil up like that. So these are the cells which actually, so if I kind of just draw it like this, these are the cells which you can see will begin to line the duct of the sweat gland, and then up here, this part is the actual glandular part which is going to secrete. So up here too, that this is where all the cells will be present lining it. So you can see how this epidermis is actually going in to do that. It will do the same with the up here. If you notice, look at this over here. So this is the basal layer of the epidermis. Notice how a sebaceous gland has been formed and how it's also formed a sheath around this hair shaft which is present inside the dermis. So you can see how the epidermis is actually going in to form all these structures. And that really helps also with wound healing. So as long as, even in areas where you have a great distance between the edges of the wound, if these epidermal derivatives are still present, for example, in people who have burns, when the burns go all the way down to the hypodermis, then all of this is removed. And then healing only it has to be done by grafting. But if there's a small wound and for example, a small burn, then if these and the epidermis in that area is completely removed, but these derivatives are still present by cells coming from this, that kind of helps with wound healing. So that's a really important thing to remember. So these are all, they kind of help the skin. So these are known as accessory organs of skin or accessory structures of skin. So let's look at each one in detail. We look at hair, and associated with hair we have a gland which is known as the sebaceous gland, and we also have a muscle which is called erector pylorem muscle. Now this muscle is not an epidermal derivative because muscle is a totally different tissue. So these three structures are always seen together. They're seen hand in hand. So let's look at the hair. The keratin on hair is what is called hard keratin. The keratin which is on the surface of your skin is known as soft keratin. That kind of peels and flakes off. The keratin on your hair is hard keratin, and the idea for it to be hard, it's hard on the nails as well, is so that it doesn't peel off. Imagine if your hair follicle, if this hair had very soft keratin, it would just keep desquamating. It would kind of keep coming off, right? So you don't want that to happen. So keratin in your hair is hard, and it is also hard in your nails. Now the melanin pigment which is present in a hair shaft may be of different types based on the color of hair. So you may have regular melanin, which kind of gives rise to really dark brown hair, or you may have phaeomelanin and eumelanin, and these kind of give rise to brown or a little reddish tint of hair. So depending on how much of these melanin pigments you have, your hair color is kind of based on that. Now when you look at hair, the part that is visible over the surface of skin, this part here, that is known as the shaft. That is the visible part. And then the root is the part which goes below the surface and is present, goes all the way down to the dermis up here. And we'll notice that it is kind of surrounded, this root is surrounded by cells and other tissue, and so this part where it's surrounded by epidermal cells and the connective tissue of the dermis, this part is what is known as the follicle. Okay, so let's take a section through the shaft up here. So if we take a section through the shaft, what it will look like is you'll have an area in the center which will be called the medulla. So the area in the center is called the medulla. So this will be the medulla. So this dark part is called the medulla. Around it, this area is the cortex. So this part here is the cortex. And the outermost layer, which is here, is what is called cuticle. And so this outermost layer is cuticle, and cuticle really consists of cells which kind of lie one on top of the other like this, like shingles in a roof. Okay, so they lie one on top of the other like that. When you actually use conditioners, what you're basically doing is that you're smoothing this cuticle. You're kind of making the cells lie one on top of the other like this. So when they do that, then your hair looks smooth. So that's what conditioners do. So that kind of makes your hair looks really smooth. When you tease your hair, you sometimes might do that. You're kind of making these cells go out, and so then that's why your hair kind of looks a little, rough at that point. Fine hair is known as vellus hair, and terminal hair is what is called coarse hair. This medulla is absent sometimes in people who have very, very fine hair, especially in the scalp. Some people have extremely fine hair, little children or others too, as adults. In them, you may not see the medulla, so there might be just a space over there. So let's look at the part of the hair which is called the root, which is below the surface. So here is this hair which is kind of lying below the surface. As it comes here into the dermis, it gets surrounded by two areas, and both of them form what is known as the follicle. It gets surrounded by, as you can see, look at this epidermis. This epidermis is surrounding the hair So it forms part of the follicle. So can you see this, how the epidermis, all of this are the epidermal cells surrounding the hair. And then the dermis around it here, this is the connective tissue of the dermis. This dermis also kind of gets closely aggregated or condenses and kind of keeps the hair, helps to protect the hair. So together, both the epidermis and dermis form the follicle, and we call this part of the epidermis the epidermal sheath, and the dermis we call the part of the dermis which surrounds this, which is surrounding the hair, we call it the dermal root sheath. So this part is also called epidermal root sheath or just the epidermal sheath, and the part of the dermis which surrounds it is known as the dermal root sheath or the dermal sheath. At its lower end, this hair gets a little enlarged and bulbous, so this part is known as the bulb of the hair. And there's a little indentation, if you notice, the bulb is not kind of flat like that. There's a little kind of little projection up here. This is an indentation up here, and this is known as the papilla, and this is where blood vessels lie, and they kind of feed the hair cells up here. So as this hair grows, these cells, because they're getting nutrition from the blood vessels underneath, they grow and they form more cells, and that's how hair gets pushed from below and it comes out. So when you cut your hair out like this, you cut off this part of the shaft, and then you notice how your hair starts growing and it kind of peeps up from here, and that's because of this part over here, which is this area in the papilla, and this has special cells here which start making more cells to push the hair up, and as it gets pushed up, then you know your hair begins to grow from below. So this area which is mitotically active is also known as the matrix. So all this area is mitotically active because it's getting nutrition at this region of the papilla. So these cells over here which are mitotically active are known as the matrix. As long as when you pull hair out, as long as the matrix gets left behind, hair will continue to grow. If you pull this matrix out, hair will stop. So for example, if you do something like electrolysis or something, you kill off the matrix, then hair doesn't grow in that part. And that's how they used to kind of, remove the hair from there. So then no hair growth was occurring. To lubricate the hair, we have glands associated with it. So these glands are always found wherever there is hair. So you will not see these glands in thick skin because you don't have hair in thick skin. These glands are known as sebaceous glands. So notice here is a sebaceous gland, and the cells in this gland make an oily secretion which has antibacterial properties, and since it's oily, it helps to lubricate the hair. So what they do is they pour their secretions which lies over the surface of the hair, and they kind of keep the hair lubricated. This gland can get, since this gland is kind of opening into this hair follicle up here, this gland can get, the pore can get sort of closed off. So let's say this is the area where it's opening. This can get closed off, and so inside the sebaceous gland will just keep producing its oil, and it will not find a way to kind of liberate that. You might end up with a little cyst. Sometimes if this sebaceous gland gets closed off and infection ensues inside, you get acne. You may have seen in people, especially during the growth years, where during puberty when people produce more hormones, like boys produce a lot of testosterone, that makes these sebaceous glands very active at that time, and so they tend to break out with pimples. Yes.
So why does your hair, like on your arm, stop growing after a certain length for the most part?
Hair grows, one is hair has cycles in which it grows, and hair in different parts of the body grows at different, two different lengths. For example, hair on your head tends to grow really long, but hair on the surface of your skin is very fine hair, and that doesn't grow as long. It just depends on the type of hair you have and where that hair is. Even in people who are very hairy, they have hairy arms and so on, it just grows to a certain length. I mean, you can't braid that hair, right? It doesn't grow long enough for you to be able to do that. The oil, because of the presence of oil, obviously it also helps with water loss. Remember, one of the functions of skin was to conserve water, so it helps with water loss. There's this muscle which is closely associated with hair. This muscle is a smooth muscle called erector pylorum. It's supplied by the sympathetic nervous system. And notice how it is present in the angle between the sebaceous gland up here and the epidermis and this hair follicle down here. So you can see how it's connecting up here to the epidermis, and at this end it's connecting to the hair follicle, and then in between this angle, this hair and this erector pylorem, is the sebaceous gland. So what this erector pylorem muscle does is, when it contracts, it kind of pulls this part down. So it kind of pulls this down and it pulls this shaft up. So the hair becomes straight like that. It also squeezes the sebaceous gland. So it kind of helps the sebaceous gland pour its secretion into the hair. And because the hair stands up erect, that's why this muscle is called erector pylorem. So it makes the hair stand up erect. In us, it doesn't matter as much because we don't trap heat between our hair. But what happens is it pulls this and it kind of pulls from here. So this part gets a little dipped in. So that's how we get goosebumps when the erector pylorem muscle contracts. You know, one area is slightly indented, another area is kind of raised like little pimples. So this is where we get goosebumps. And you notice when you get goosebumps, your hair stands up. In animals, it helps because it helps them to trap heat. Plus, at the same time, it also gives them, some animals, when the hair stands up, it gives them a predatory look, like they look frightening, and so that kind of keeps their predators at bay. Okay, so that's the function. And us, of course, the idea, while it makes the hair stand up, the idea is not to trap heat. In us, its importance is the fact that it squeezes the sebaceous gland and helps the sebaceous gland to kind of pour the secretions into the hair follicle and lubricate it. So here again is a section. So here you can see the hair follicle in greater detail. So this central area, notice, is the medulla. Part outside of it, this is the cortex. And then this narrow area is the cuticle. And then here you can see the epidermal and the dermal root sheath around it. You can kind of ignore this glassy membrane and so on. And here notice this erector pylorem muscle and the sebaceous gland, and see the angle. The sebaceous gland invariably tends to lie in the angle between the hair and the erector pylorem muscle, so that it becomes easy for this gland to be squeezed. Now I told you hair grows in cycles, so you may have found, you know, that when your hair falls, sometimes your hair growth is more, other times it's less. So your hair follicles go through cycles, so they're inactive for some time and then they become active again. However, there may be conditions where the hair follicles remain inactive all throughout. So then your hair doesn't grow, or you get just like peach fuzz. That condition where the hair follicles are inactive is known as alopecia. This could be due to alopecia, could arise stress, for example, can give rise to alopecia. You may have some fungal infections which give rise to alopecia, or it could be some endocrine condition. And in males, they tend to kind of have baldness, which tends to be at the crown of the head, whereas the part, you know, just above the ears, they don't get bald there. That kind of alopecia is a little different because it is dependent on how the hair follicles at the crown of the head react to a byproduct of testosterone. So this is kind of, you know, it's called male pattern baldness, and it runs in families. So if the father tends to have that kind of baldness, more than likely that the son will inherit that, okay? So that's a little different. That's because of the way, and it's seen that only the ones in the crown, the hair follicles, they react to the byproduct of testosterone, and so they don't grow. So if you transplanted plugs from the, you know, the back of the head to this part on the crown, the hair will grow back. So that's what they do in hair transplants. Hirsutism is the exact opposite, where you have excessive hair. Some races by nature are generally more hairy than others, but otherwise typical hirsutism is seen whenever there are certain endocrine diseases, where too much steroid hormones are being produced. Such patients tend to become hirsute. They tend to get a lot more acne and so on, because it makes the sebaceous glands also very, very active. I told you about acne. This is because of infection of the sebaceous gland, and then, you know, it kind of gets pustular, and you know, that area gets inflamed and it rises over the surface, and, you know, you have to take various treatments, keep the skin very clean. sometimes, and acne tends to be more predominant during the growing years because the sebaceous glands are more active at that time because they are reacting to the hormones produced during puberty. Here you can also see the hair papilla. This is the area where the blood vessels and nerves are. And this part here is the matrix, which is where all the mitotically acting cells are present. And they give rise to the hair, and then they kind of help to push the hair from below. Then we have sweat glands, which is again an accessory organ of skin. Sweat glands are also known as sudoriferous glands. This is another name for sweat glands. So whenever you have different names for anything, it's always important to kind of keep that in mind. They produce sweat, which is usually acidic in nature, which prevents bacterial colonization. And sweat by itself also helps to flush away any bacteria that may be on the surface of the body. It flushes away waste, so it has an antibacterial property. Sweating is controlled by the sympathetic nervous system. So whenever you're very frightened, you'll find that you tend to sweat a lot. And that's because of the sympathetic activity. Also on a hot day, to keep make sure that homeostasis is maintained. Remember in the first lecture we did, on a really hot day you sweat more so that the sweat lines the surface of your skin, and then when it evaporates your body cools down. Also the sympathetic system, and that's because of activation of the sympathetic system by the hypothalamus, which is the thermostat in the body. On a cold day you don't sweat as much, but the sympathetic system is stimulated differently. Here it causes vasoconstriction of blood vessels in your skin. So you may have noticed when it's cold you tend to look paler. When it's warm you tend to look more flushed because the blood vessels are dilated when it's warm. When you're cold, the blood vessels are constricted, giving you that pale skin. Now there are two types of sweat glands. Most of the sweat glands in your body are this kind, which is called the eccrine sweat gland. This eccrine sweat gland is a very watery kind of sweat that is produced. And in your pubic areas and in the axilla, you have this sweat gland which is called apocrine sweat gland in the pubic and axillary areas. This sweat is a little bit more viscous or thick, milky, and if because of bacterial overgrowth, that's what gives the typical body odor. So when you sweat, initially sweat doesn't have a smell. It is because of bacterial growth that sweat begins to smell. And the pubic and axillary regions are moist. You keep your arms by the side of your body. The pubic region also is a moist area, always covered. So then bacterial growth is more prominent in those areas. And that, when it acts on sweat, that's what gives the body odor. You have special sweat glands present in your ears which produce wax. These sweat glands are known as ceruminous glands. So they produce wax. So this is in your external ear canal, or what is also called external ear canal, or also called external auditory canal. So this produces wax which helps to lubricate your external canal, external ear canal. It also helps to trap anything that might, make its way there. The mammary glands are also a type of modified sweat gland. So the mammary glands are also a type of modified sweat gland. What you'll notice from this picture is that the eccrine sweat glands, they pour their secretions on the surface of the skin, and that's the sweat pores. The apocrine sweat glands, they kind of open into, very close to a hair. You can see this, they open on the surface, but into a hair follicle. And that's where, the bacterial growth can kind of ensue and give rise to the smell. So let's take a look at these sweat glands.
We ventured inside every hole in the body today, and our last orifice produces a substance which can sometimes be the pits. Take a look. Sweat glands. It's normal and it's good to sweat.
But it can also be stinky, especially during puberty when those hormones turn on and the bacteria on the bottom causes the odor. But then there's also pheromones, which causes attraction too during puberty as well. So sweat can actually be, well, it is a good thing.
As long as you don't leave it on for weeks on end.
That's right.
Then it becomes a
Actually,
problem.
a little bit more, yeah. Deodorant.
Do you know, I came about something that is pretty interesting, a study, buttermilk, that we know is good for you. It's full of nutrients. Yes, it has some fat in it. It's healthy. But the study said that it actually may decrease sweat production.
A little
Right
buttermilk.
here. Do you like buttermilk?
I don't know that I've ever had straight up
Look how
buttermilk.
thick it is. Oh my
Wow.
gosh, it's like cream.
I'm not going to sweat the rest of the day.
What does it taste like?
Don't let 'em
Put it
see
in
you
butter,
sweat.
wash it on you.
You don't drink it much?
I've never had it unless
You know,
it's part
we-
of
I'm
making
Polish.
something.
We use buttermilk for.
Well, another thing you don't want to do or that you do want to do is avoid spicy foods because that can really make you sweat, and also things like garlic because that's just going to add to the odor
Yeah,
and things like
I
that.
love that garlic sweat though.
There you go.
And I want to ask you guys a question. How do you feel about antiperspirant deodorants? Because I'm going to lay this on the table. As I've gotten older in life, a lot of days I haven't been wearing it, and I haven't found that I'm.
And yet you're still single. I wonder why.
I want to bring this up because it's one of those things where,
I agree
when
with you.
I was younger, when I was a teenager, I would get home sometimes and be like, who's cutting an onion?
Yeah, right. But sometimes I like to give my body a little break from those chemicals,
And that's one of the reasons I've not been using it every day. And I say as long as you're not, smelling up the joint,
You sit the
it's
closest.
probably okay to occasionally avoid it, right?
Is it okay over there?
Yeah, he's okay, but if
I'll tell you when
if
I
you
smell.
or if people are running away from you, then you might want to use some deodorant. He's good. He's good. Oh,
See, I don't-
no smell.
I wore it today.
For really excessive sweaters, there's other medications you can take as well as the use of Botox in areas if you're really an excessive sweater. In your armpits, your hands, your feet, and your groin. Actually, I've treated all of those areas with Botox, and it works well.
So the reason I showed you this video is for, everybody uses deodorants and antiperspirants. There are some people who are prone to sweating a lot more than regular people. We all sweat a lot when we run and do activities. There's some people, unfortunately, really sweat excessively. And they can get dehydrated also. So as he said towards the end, Botox is one of the things which, when we think of Botox, we only think of people using it to prevent wrinkles, but it really had, that was not the original use that it was aimed at. It was really aimed to prevent sweating. So when you inject it, you paralyze the muscles so then it doesn't sort of cause sweating, and so it really gave a lot of relief to these people. They realized when they were doing that that area kind of looked smooth, and then they started using for other things. Okay. So let's look at a few questions. So in a person suffering from acne, what do you think you could expect to find? Hyperactivity of the sebaceous glands. Yes, remember, acne was when the sebaceous gland, when infection of the sebaceous gland ensued, that's when you got acne. So hyperactivity of the sebaceous gland. Okay, let's look at nails. So again, this is here the cells, it's the epidermal cells, they're very, very tightly packed together. Here also there is hard keratin. And when you look at the nail, there's a part which is below the skin. You can't see that. That area is called the nail root. And then the part which you can see up here, this area is called the nail body. This part, which kind of is the one that you see on the outside, is the free edge. This is the area that you cut. And then up here, you see the cuticle, which has another name, which is known as the eponychium. This is the one when you get a manicure done, because it's dead cells, it doesn't hurt. They kind of push it back just so that they can have a longer nail body in order for you to see. And up here in this nail root under the skin, so here if you look at this picture, this part here is the nail root up here, which is under the skin. This is the nail body, which you can see. This is the free edge of the nail which you cut. It's known as the hyponychium. Hypo meaning below. This part here is the cuticle or eponychium, which is what you push back up here. This is the part which is hidden, so it's under the skin. This area, just like a hair follicle, this area is also the part which grows. It's called the nail matrix. Whenever you see the word matrix, one of the things is that here there are cells which are very active. So that's why when you cut the nail from here, the nail gets, these cells produce more cells and they push the nail forward. So, it grows from behind and it grows forward here. There are cases where people lose their nails. As long as the nail matrix is kind of left behind, it will help the nail to grow. If this is also removed, then the nail won't grow. So there's not too much to do, too much about the nails. So let's answer this question. What's the advantage of having hard keratin in nails instead of soft keratin? Very good. Just like hair, same principle applies here. It prevents nails from peeling off. So that's why you have soft keratin. That's why you have hard keratin, sorry. Makes it easier to paint nails? Okay. Which of the following are accessory organs of skin? D. Epidermis is part of skin. Remember, dermis, epidermis, hypodermis. So epidermis is part of skin. It's not an accessory organ of skin. Accessory means which is an additional. So this is, epidermis is part of skin itself. These are all additional structures. So it's not this. It can't be this either because dermis also is part of skin. So hair, nails, sweat and sebaceous glands are accessory organs of skin. Now, cancer is always a big scare when anyone gets it, and since skin is the largest organ, also it's exposed to ultraviolet light, so different types of skin cancers are pretty common. So the three types of skin cancers that we see are the basal cell carcinoma, the basal cell carcinoma, which is this one. It's also known as a rodent ulcer because it kind of looks like a little rat bite. So you get a little ulcer like this on the surface of the skin. This one is called squamous cell carcinoma, and this might be keratinized. These two are not malignant in the sense that they do not spread by lymphatic or bloodstream. So you can kind of contain that cancer in that area if you remove it. So their prognosis is very good. So if anyone has basal cell carcinoma, you kind of remove this area, it would not have spread. If it does spread, it's very, very late and very, very slowly. So the prognosis is always very good. The same goes for squamous cell carcinoma. Basal cell is the best prognosis and the least malignant of carcinomas. The one carcinoma which spreads and becomes dangerous, and when it spreads, that's what we call malignant, is this carcinoma known as malignant melanoma. Melanoma because it's taking origin from the melanocytes. So in order to see whether one should be sort of wary or one should kind of get that area biopsied, dermatologists came up with a rule which is called the ABCD rule, or we also use the word E. They've also added the word E to tell the prognosis of carcinoma. So A in this case stands for asymmetry. B stands for border. Border. Yeah. A is asymmetry. They're telling what the prognosis is going to be like, and I'll tell you what their criteria are. So B is border, C is color, D is diameter, and E is elevation. So they just added the E. Asymmetry. So if you look at a lesion on anybody's skin and you see that there's a lesion up there, you kind of draw a line right through the center of the lesion. If the two sides are asymmetrical, like in this case, you can see this one is like this, right? And this one is this way, so they're not symmetrical, then the prognosis is not good. The more symmetrical it is, the better the prognosis. So in other words, if she just had a round lesion like this and you drew a line and both sides were symmetrical, it's better. But when there is asymmetry, it's not good. The prognosis is not good. Border. If the border is irregular, the prognosis is not good. If the border is regular, so in this case, in this lady's case, can you see that the border of the lesion is irregular? And if instead she had a round thing like that, the border would have been regular. The regular border is better, or better prognosis. Irregular border is not good prognosis. Prognosis means how long will the person live? What are their chances of survival? That's what is meant by prognosis. C is color. The more colors there are in a lesion, the worse the prognosis. So, for example, this is a picture, so you can't see very well, but sometimes a person may have a lesion where there's black and there's a little brown, maybe some other color in it. The more colors you see in the lesion, the worse off the prognosis is going to be. D is diameter. They say that a lesion should not be more than the top of a pencil eraser. You know, the little top of a pencil eraser that you have on the top. If it's more than that, again, the prognosis gets worse. Obviously, the more it is than that, the worse it's going to be. E, they brought on this other thing for E. They usually just, in many books, you'll just see A, B, C, D, but they also look for E, which is elevation. The more the lesion is elevated above the surface of the skin, the worse the prognosis. So in this woman's case, you can see she's kind of got pretty much all the, she's got a really bad prognosis. You can see that this is like, even in the picture, you can see that it's over the surface of the skin. If someone has something which is plush with the skin, like it's not rising over the surface of the skin or not elevated over the surface of the skin, that's better. So if in a lesion which is elevated over the surface of the skin, like in this woman, that's bad prognosis. Okay? So you must know what this ABCD stands for. A is asymmetry of the lesion, B is border of the lesion, C is color, how many colors you see, D is diameter, shouldn't be more than that pencil eraser, and the E was elevation above the surface. Apart from
Even if there's only like one or two of those, like they only have two of those.
well, if they have all, obviously the prognosis is going to be really bad. If they have a couple, the prognosis is going to be worse than if they didn't have that. We have other conditions that you might see in skin. You might see children being born with little birthmarks. They might have a little area which kind of disappears, usually tends to disappear as they're growing up. Such a little birthmark most of the time is due to a tumor of blood vessels known as a hemangioma. And most often this kind of goes away with time. Some people it doesn't. I mean, especially if it's pigmented and so on, it kind of will remain. Yes. a tumor of blood vessels. And then another interesting condition, which is also a tumor of blood vessels, is something known as turban tumor, which is seen in people on the surface of their head. These blood vessels sort of really form a huge tumor, so it looks like they really have a turban or a cap sitting on the top of their head. So that happens sometimes in people. So this is known as a turban tumor. There are many other conditions of skin, but we just do this, and you must know the other things that we talked about in skin color changes. For example, what is cyanosis, what is erythema, what was jaundice, so those other skin conditions that we see and what they represent. Next, let's look at burns, because burns affect skin. And whenever burns, the more area that is burnt, because skin is a protective organ and it helps to conserve water, it also protects you from infection. So when people have burns and the burn area is very, very large, we are always worried about infection and fluid loss. These are the two things we are always concerned about when people have burns, which are especially second or third degree burns, and the burn involves a large area of skin, because if it involves a large area of skin and the epidermis has been removed from there and part of the dermis also goes, infection can quickly come in. Plus now this protective area is gone, so fluid loss can go around. So you get worried about that. Now let's look at the three classifications we have of burns. First degree burn is where the epidermis is involved, just the epidermis, so that area looks a little red. We say erythema, so it looks a little reddened. Sunburns are one good example of first degree burns. So they are painful because the nerve endings, if you've ever had a sunburn, you know how painful it is, you know how red that area gets, because the nerve endings, so just the epidermis is gone, so the nerve endings get exposed and that becomes painful. Second degree burns are seen when the epidermis is lost and a part of the dermis as well. So these burns usually show up as blisters, as you can see up here. These also are painful because you can see nerve endings are still exposed. And if the second degree burn involves a large area of skin, again, like I said, infection and fluid loss, you're very worried about that. So these two are painful. Third degree burns are when the epidermis, the dermis, and even going down to hypodermis, it may go down to muscle and bone down below as well. In this, everything is lost, so the area looks grayish, leathery. And because notice how the nerve endings would go, so these kind of burns, person doesn't feel pain. But because they have lost so much of the skin, epidermis and dermis, this is the one which you're really worried about, because infection can ensue, fluid loss can happen, a lot of it, and you're always worried about it. And in second degree and third degree, in both cases, depending on the areas involved and how much of it, skin grafting is usually required. So let's take a look at a video on this.
Burns are skin injuries caused by heat, chemicals, electricity, or radiation. Your doctor will recommend treatment based on the size of your burn and the layers of skin the burn affects. Your skin has three main layers: the epidermis, the dermis, and the hypodermis, or subcutaneous layer, containing fat, blood vessels, and nerves. Beneath the skin are tissues such as muscle, fascia, and bone. First degree or superficial burns affect only your epidermis. The burn site appears red and dry with no blisters and is mildly painful. Second degree or partial thickness burns involve your epidermis and portions of your upper dermis and lower dermis. The burn site is red and moist and may be blistered, swollen, and very painful. Third degree or full thickness burns extend through your dermis and into the hypodermis. The burn site appears patchy in color, ranging from white to brown, with a dry, leathery texture. Because the burn is so deep, it causes little or no pain. Fourth degree burns involve the destruction of all layers of your skin, sometimes extending into the underlying muscle or bone. These burns are brown, dry, charred, and almost always painless. You can treat your first degree burn by soaking it in cool water for a few minutes. To soothe and protect the tissue, apply an antibiotic ointment and cover with a clean, dry bandage. You can take acetaminophen or ibuprofen for pain. Care for a second degree burn by soaking in cool water for several minutes. Apply an antibiotic ointment to prevent infection and cover with a clean, dry, non-stick bandage. Change your bandage every day and make sure your hands are clean. Acetaminophen or ibuprofen may help with pain and swelling. If you have a third or fourth degree burn, go immediately to an emergency department. If you can, elevate the burned body part higher than your heart. You will also need to seek medical attention if your burn is larger than 3 inches in diameter, or if it is located on your face, hands, feet, groin, buttocks, or over a major joint.
Okay, so let's answer this question. Which of the following burns would not be painful? Third degree, yes, first degree is painful. The pain may not be very severe, but it's definitely painful. First and second degree are painful. Third degree is not painful.